Καλησπέρα σε όλες και όλους που και αυτό το απόγευμα συνδέονται μαζί μας στη σειρά των μαθημάτων Υγεία και Θρησκεία. Σήμερα έχουμε την εξαιρετική χαρά και τιμή να φιλοξενούμε σαν κεντρικό ομιλητή τον καθηγητή Harold Koenig, ο οποίος είναι καθηγητής της ψυχιατρικής στο Πανεπιστήμιο του Duke και ο οποίος έχει εργαστεί πολλά χρόνια πάνω σε αυτό τον χώρο και έχει συγγράψει πάρα πολλά άρθρα και πάρα πολλά βιβλία και είναι γνωστός και στην Ελλάδα. Ο καθηγητής Koenig τελείωσε το Πανεπιστήμιο του Στάνφορντ και την Ιατρική Σχολή του University of California, San Francisco. Τελείωσε ψυχιατρική, γυριατρική, βιοστατιστική και έγινε προοδευτικά καθηγητής της ψυχιατρικής και της ιατρικής στο Πανεπιστήμιο του Duke. Είναι adjunct professor σε πάρα πολλά πανεπιστήμια, στην Σαουδική Αραβία, στο Ιράν, στην Κίνα και γενικά χαίρει εκτιμήσεως σε όλο τον κόσμο. Έχει συγγράψει πάνω από 600 δημοσιεύσεις, πάνω από 100 άρθρα, πάνω από 50 βιβλία και έχει τιμηθεί με πολλά βραβεία, μεταξύ των οποίων το 2012 το Oscar 5-Star Award της Αμερικανικής Ψυχιατρικής Εταιρείας, το 2021 το Frank Minirth Award for Excellence in Christian Psychiatry and Behavioral Medicine from AACC και βεβαίως είναι γνωστά τα course τα οποία έχει κάνει όλα αυτά τα χρόνια και τα οποία θα κάνει από ό,τι έμαθα πριν από λίγο και τον ερχόμενο χρόνο στη Βιέννη που ελπίζω να μας πει γι' αυτά. Professor Koenig is a great honor and a pleasure for us and for all people that are attending today's health and religion meeting. We do have many psychiatrists, many lay people, theologians, and we're so happy to listen to your presentation. I had the chance to speak in Greek for your significant work and warn them that you will tell us more about the future training courses that already people are interested and want to hear, but at this time we would like to listen to your presentation entitled Religion, Spirituality and Health, Research and Clinical Applications. Thank you again. The floor is yours.
Thank you, Dr. Linus. It's a great pleasure to be able to speak to you and to all of your colleagues and to the medical students and fellow faculty. Okay, so I'm going to go ahead and start. I'm going to share my screen. And here we go. And hopefully everything will work. There. And I will adjust this just a little bit, get rid of this floating. Okay, so I think now we're good. So I'm going to be speaking to you all on the topic of religion, spirituality, and medicine. I'll be covering some research and also some clinical applications. In terms of overview, first of all, I'm going to define the relationship between terms such as religion and spirituality. Then I'll look at the research examining the relationship between religion and mental health, and then look at the relationship with physical health, provide you with a model that helps to explain how religious involvement influences health, and then talk about some clinical applications in healthcare. And then I'll come up with some conclusions and provide you with some further resources if you want to know more about this. So the terms religion and spirituality, are they the same or are they different? So this is very, very controversial with regard to definitions, because there are many definitions that people have in the field. I'm going to present my view of the definitions. So first of all, religion. Religion is unpopular and potentially divisive because people believe different things and they believe them very passionately. Spirituality, on the other hand, is popular. It's inclusive of everybody, common to all, and it's pretty much defined by the person themselves. Now, through most of recorded history, spirituality and religion have been considered largely the same. But in the last 30 years or so, with the increasing secularization, spirituality, at least in academic settings, has become separate from religion. So I'm going to now visually illustrate how spirituality, this term spirituality, has been changing. This is the traditional definition or conceptualization of spirituality. Here is the spiritual people were those who were the deeply religious. So someone who was called spiritual was a subset of religious individuals whose lives were devoted to their religious faith, and these would be the clergy oftentimes, and religious leaders would be the spiritual ones. And then there were the more superficial religious people that made up, the rest of the religious people. And then there were the completely secular people. Now, this model, this traditional model, was very easy to do research on because you could give a religiosity scale, and those who scored the highest on that scale would be considered the spiritual. And then those who scored lower on that scale would be the more, generally religious, but not spiritual people. And then there would be those who scored low on the religiosity scale, who would be more secular in their orientation. And then you could compare their positive mental health and their negative mental health, and ultimately also compare between these groups their physical health, their cardiovascular health, their cancer, mortality. You could compare those who scored high on religiosity, the deeply religious, called the spiritual, the more superficially religious, and those who were not religious at all. So this is the traditional understanding. Now, things have been changing in the last 30 years, as I said earlier. Now, spirituality has expanded out from being a subset of religious people now to include everybody who's religious and even those who are not religious. So now you can be spiritual but not religious. You can see this group here. And then those who are neither spiritual nor religious. So this is not terribly bad because scientifically you can compare people who would categorize themselves into both religious and spiritual, those who are spiritual but not religious, and those who are neither. And then you could compare their mental health and their physical health to see who is actually healthier. Now, the issue here is that spirituality has expanded even further. The reason being is because researchers have tried to further identify or characterize individuals who describe themselves as spiritual, but not at all religious. How do you characterize these individuals who use a religious word, spiritual, to describe themselves, but who are not at all religious? So that has created a vacuum. It's created a vacuum, and it has caused a further expansion of spirituality to include mental health. So now the way spirituality is defined and measured is that it includes measures of mental health in the actual definition and conceptualization of spirituality. Now, unfortunately, that is a problem. That's a big problem, because if you define spirituality to begin with as good mental health, well, of course, it's going to be related to good mental health. And the poor secular people have no chance at all here. No chance at all, because spirituality a priori has been defined as good mental health, meaning and having meaning and purpose, being connected with others, having well-being and peacefulness. All of that is good mental health. And that's going to correlate with mental health and with mental disorders such as depression, suicide, anxiety, and also with better physical health. So this is the way it's now being conceptualized. Spirituality, really, you can't really do research with that term. So I'm going to summarize here. In discussing the research, the scientific research, I'm going to be using the term religion, because that is what you can actually measure and is sufficiently distinct to avoid any conceptual overlaps with mental and physical health, which are actually the outcomes of spirituality. Now, when measuring spirituality for research, and I wouldn't discourage the measurement of spirituality in research, but the measures should not be contaminated with positive psychological states or positive character traits, as it is now being done. This will help to avoid the defining spirituality a priori as good mental health and the tautological associations that will otherwise result. And that will make these findings completely uninterpretable. If you're correlating something with itself, of course it's going to be correlated. In clinical settings, however, now listen closely, in clinical settings, a broadly inclusive term such as spirituality should be used and be defined by patients themselves so as to maximize connection, engagement, and conversation with patients wherever they're at in terms of how they define spirituality and their own spirituality. But remember that that doesn't work for scientific research that is trying to understand the causal factors that lead to better mental and physical health so that interventions can be targeted at the causal factors so that they can enhance mental and physical health. Okay, I know I've taken up a good bit of my time defining these terms, but I think it's critical if you're talking about research. Okay, let's do some reviewing of some of the research. Now, a lot of this, the latest research on religion and health is contained in the upcoming Handbook of Religion and Health, 3rd edition. Oxford University Press is coming out. It will be out in June of this year. Now, what's out right now is this book published by Academic Press in 2018, Religion and Mental Health, Research and Clinical Application. But this handbook is going to cover pretty much all of the different aspects of physical health as well, in addition to public policy and, all of these other things as well. And if some of you are interested, more recently, I've got a couple of articles that we published in the British Journal of Psychiatry, Advances, with colleagues, looking at the latest research and then the clinical applications within the field of psychiatry. Okay, and you can get those, all you got to do is get those. And if you want them, I'll send you a PDF. Just send me an email. Okay, let's review now some of the relationships between religion and mental health. Depression. Depression, you're going to see a lot of depression if you're a clinician. It's the most common emotional disorder in the world and the most disabling. Heart disease is the only condition of the 350 different international classification of disease disorders. Heart disease is the only medical condition that has been found to be more disabling than depression. So depression is very common, it's very disabling, and it affects medical outcomes. So now in terms of religious involvement, those who are more religiously involved are less likely to experience depression. And if they do get depressed, they are more likely to recover from depression. And a lot of our research in the medically ill have shown that the more religious person, the person who is more actively involved in a religious community, who has a strong faith and belief in God, they just experience less depression when they're sick, and they recover from depression more quickly. So in 61% of the studies worldwide, this is actually a systematic review of the literature in the 2012 edition of the Handbook of Religion and Health. So it's a bit dated, but of those studies conducted prior to the year 2010, over 60% find that the religious person just experiences less depression. And if you look at the higher quality studies, 2/3 of those studies find that the religious person does better in terms of their depression. 6% of studies in this systematic review found that religious people experience more depression, and that is depending on their particular circumstance. And if you look at it overall, though, there are 10 times more studies finding less depression among the more religious compared to more depression. Okay, so more recently, the Harvard School of Public Health did a study of nearly 10,000 young people, average age of 23 years, and followed them over a period of up to 6 years. And what they found that the risk of developing depression over those 6 years among these young people was about 1/3 less likely among those who are more actively religious, those who are attending religious services once a week or more. So even among young people, it seems like being involved in a religious community helps to prevent the development of depression over time in this longitudinal or prospective study. And these findings emerged after controlling for over 24 other predictors of depression. And that's after doing a conservative correction called the Bonferroni correction in the analysis. There was still an almost 1/3 reduction in risk of developing depression, independent of all of those other covariates. Suicide. Consequently, if people are less depressed, you would expect suicide rates to be lower. And that is exactly what we find. In that systematic review, there were 141 studies in the medical literature, psychiatric literature, psychology literature, that examined the relationship between religious involvement and suicidal thoughts, suicide attempts, and completed suicide. And of those 141 studies, 106, or 75%, found that religious people just have fewer suicidal thoughts. and are less likely to commit suicide. And that makes perfect sense because they're less depressed. If you have less depression and you're more hopeful and optimistic, well, you're not going to be committing suicide. Now, more recent research has, since 2010, has reaffirmed those findings. Here is a study of over 20,000 Americans. This is a random sample of over 20,000 Americans of all ages over the age of 18, and they were followed for 18 years. This is the NHANES 3 study. This is a major study that, in fact, has been critical in medicine in determining rates of and predictors of cardiovascular disease and stroke. So they happen to measure attendance at religious services during the baseline interview at the start of the study. So they have information on attendance, and they have a lot of information, particularly including suicide and completed suicide among these 20,000 people, randomly selected Americans, followed over 18 years. What they found after controlling for, taking into account age, gender, size of the household, previous suicide attempt, and drug use, after controlling for that, they found that there was a 94% reduction in risk of completing suicide among those attending religious services twice a month or more often. So twice a month or more often attending religious services predicted a 94% reduction in risk of completed suicide over those 18 years in this random sample of Americans. Here's another study published recently in the Archives of General Psychiatry, or JAMA Psychiatry. Again, these journals are the best in the world. Again, looking at the incidence rate of completed suicide, you can see here, this was out of the Harvard School of Public Health. And what they found was an 84% reduction in risk of completed suicide among those attending services at least once a week or more often, compared to those who never attended religious services, where the suicide rate was 7 times greater prior to correcting for other predictors of suicide. So we have a 7-fold difference in the incidence of suicide among those attending at least weekly versus not attending at all. Again, published in the world's top psychiatry journal, involving nearly 90,000 women. These were all nurses, by the way. Okay. Now, what about deaths of despair? Deaths of despair. What is that? Deaths of despair are deaths from alcohol use, cirrhosis of the liver, drug use, and suicide. So these are deaths of people who are despairing of life, who are either suicidal or who are addicted to drugs or alcohol. And so what, again, we find is that there is a 70% reduction in risk of dying from a death of despair among a sample of approximately 66,000 women followed for 16 years, looking at deaths from alcohol, drugs, or suicide. And not only is there a 70% reduction in those attending religious services at least once a week, but there is a P for trend in the relationship. That is very important because a P for trend means that there is a dose-effect response. The greater the dose of religious involvement, the greater the impact on the outcome. And this is suggestive of a causal relationship, that indeed that religious involvement is actually causing a lower risk of dying from a death of despair. Now, this is in women. What about men? The same relationship was found. Again, this is out of the Harvard School of Public Health. There's Howard Koenig, there's Tyler Vanderweel. They are the ones who have done this study. And this is published again in JAMA Psychiatry. And this is a 26-year follow-up of over 40,000 health professionals, all men. And once again, they find a nearly 50% reduction in risk of dying from a death of despair. Key for trend in the data, suggesting a causal relationship between weekly religious attendance and a lower risk of dying of a death of despair among men, healthcare professionals in particular, over a 26-year period. Okay, so what about alcohol use, abuse, and dependence? Again, between 80 and 90% of the studies published in medical and psychiatric and medical journals find that religious people just don't use as much alcohol, don't abuse it as much, and don't become dependent on it as much. Again, this is 80 to 90% of a systematic review in the Handbook of Religion and Health, second edition, which was published in 2012 by Oxford University Press. Illicit drug use, the same finding. Religious people just don't use drugs, don't get addicted to them. Here is a study of young people. This is an 18-month prospective study of a random sample of about 500 young people who have been referred to child protective services because of abuse in the home. We know that these kids are at great high risk for developing a substance use disorder as soon as they get out. And in fact, those youth who have been abused, who have a strong religious faith, are more than 50% less likely to develop a substance use disorder over an 18-year follow-up, after they leave child protective services. So even among young people, religious faith, high-risk young people, seems to make a difference, at least in terms of developing a substance use disorder. Now, with regard to anxiety and PTSD, again, you find this relationship. Because religious involvement is a coping behavior, it helps people cope with stress better, including severe stress from post-traumatic stress disorder. This is true in about half of the studies, and in 11% of the studies, you find that actually there is more anxiety among the more religious. Most of those studies finding this positive relationship, though, are cross-sectional. And typically, religious involvement is a result of being anxious. People who get anxious tend to turn to religion to help to calm their anxiety. And that's exactly what we see. And when you look at experimental studies or randomized controlled trials, nearly 3/4 of these studies find that religious or spiritual interventions significantly reduce anxiety. Okay, here's a study we did of veterans. This is a random sample of U.S. veterans. This is the National Health and Resilience in Veterans Study. And what we did, we administered the 5-item Duke Religion Index, which is the most commonly used measure of religiosity in the world. It's only 5 items. It measures religious attendance. It measures private religious activities like prayer and scripture study. It measures the person's strength of their relationship with God, intrinsic religiosity. And in this particular study, we divided the scores into the upper half and the lower half. What we found that those scoring in the upper half, the more highly religious veterans, seem to be protected from lifetime post-traumatic stress disorder. You can see that there is a more than 50% reduction in that risk. Lifetime major depressive disorder, a 50% reduction, about a 1/3 reduction in risk of a lifetime alcohol use disorder. And with regard to current PTSD and current alcohol use disorder, there's a 70% or greater lower risk. Now, this is a cross-sectional study. So these are cross-sectional relationships, not like the prospective relationships like I was describing earlier. Now, not only are mental disorders less frequent, but also the positive side of mental health is better among those who are more religious. Religious people are just happier. They're more satisfied with their lives. They have greater well-being. They have more optimism. They have more hope. And that's not surprising, not surprising. But according to systematic research, again, this is all in the second edition of the Handbook of Religion and Health, over 80% of the 326 quantitative studies find that religious people have greater being. And of those 326 studies, less than 1% find that religious people are not as happy as those who are less religious. But that's 80 times less likely. There are 80 times more studies showing that religion is related to greater well-being than there are studies showing that religion is related to lower well-being. And of course, these are all statistically significant relationships that I'm reporting here. And as the quality of the study goes up, you find that the findings are even more likely that those who are more religious are happier. Again, as I said, almost all of the studies on meaning and purpose in life show that religious people have more of them, and of the highest quality studies, all of the studies find that. Greater hope in 3/4 of studies, greater optimism in over 80% of studies, and people who are more hopeful, who have greater meaning and purpose in life, who have greater optimism. That has consequences in terms of a patient's motivation towards recovery. When people get sick and get in the hospital, they need to have meaning and purpose in life. They need to be hopeful and optimistic if they're going to do that hard work of rehabilitation to get better from heart disease or stroke or other medical conditions, or even after psychiatric conditions. If people have more meaning and purpose and hope, they're going to do better in terms of recovery. Okay, social support. Over 80% of studies show that religious people have more support. They have more friends, particularly those who are engaged in a religious community. Not surprisingly, delinquency and crime are substantially lower among those who are more religious in 80% of studies. And again, over 80% of the best studies find lower rates of delinquency and crime among those who are more religious. Not only that, but children who are raised in a religious environment do better in school. They're more likely to graduate from high school and go to college. They have higher grade point averages. And this has all actually been further documented just recently by researchers at the University of North Carolina at Chapel Hill, who are our rivals, of course. Duke and Chapel Hill are rivals. But there is a researcher there who's written a book on the impact of religious faith in terms of education and completing education, being able to get a good job and to do well. Okay, so that's enough. Marital stability and satisfaction, nearly 90% of studies show that religious people just have stronger marriages. They have more satisfying marriages. They're less likely to cheat on their spouse. They're more likely to have two parents in the home to raise the children. Here's a study again out of Harvard. This is 66,000 initially married women, and they were followed over 14 years, and they looked at the risk, the hazard ratio for divorce or separation. Once again, you find that between 40 and 50% lower risk of divorce or separation among those attending religious services together. And you see this P for trend suggesting a causal relationship of this religious involvement in terms of preventing divorce or separation. Now, here's a model out of the third edition of the handbook that tries to explain how religious involvement affects mental and social health. I'm running out of time here, so I want to move a little quickly, but basically, religious involvement affects a person's mental and social health across the lifespan, from infancy all the way to, the end of life. Okay, let's look at physical health. First of all, we'll look at health behaviors. Religious involvement is related to everything health related. Religious people exercise more. They have less extramarital sex, safer sexual practices. The one health behavior that seems to be worse among the more religious is that they eat too much. They're heavier. They weigh more. So of studies that have looked at this, 39% have found that religious people are significantly heavier, and only 19% show that they are not as heavy as those who are less religious. So basically, religious people, they actually eat a healthier diet, but they eat too much of that diet. Eating is the one sin that is allowed in most religious communities. So that's an issue that needs to be worked on. Cigarette smoking, 90%, once again. Religious people don't smoke. They don't use cigarettes. They don't use drugs. They don't use alcohol. They lead healthier lives. And so you would expect them to be healthier. And that's what you indeed find. Research shows, again, this is in the handbook, the second edition, and most of the research edition is reaffirming these earlier findings. But more than half of studies show religious people have measurably better immune functions and better endocrine functions as well. Lower levels of cortisol, epinephrine, and norepinephrine, which are the stress hormones. Cardiovascular functions are better among the more religious. Lower blood pressure in the majority of studies. Better cardiovascular functions, such as heart rate variability, cardiovascular reactivity, levels of C-reactive protein. All of these are indicators of cardiovascular function. They're all in almost 2/3 of studies show that religious people have just a better function in terms of their cardiovascular system. And then coronary artery disease and deaths from heart disease overall is lower among those who are more religious. So that's true in about 2/3 of the studies. Here's another study out of the Harvard School of Public Health. This is published in the American Journal of Epidemiology not long ago. This is a 12-year prospective study of 44,000 women. This is the incidence of self-reported hypertension. And you can see that among those women attending religious services more often, you find a significantly lower likelihood of developing self-reported hypertension during that 12-year follow-up period. And again, you see this P for trend suggestive of causality. Now, the effects are only about, between 7 and 10% reduction in risk. But if you could reduce the risk of hypertension by 10%, you could lower the risk of stroke and heart disease by 20%. That's what the figures are, because hypertension is such a strong driver of heart disease and stroke. If you could reduce it by just 10%, you could drop the cardiovascular disease risk and stroke risk by 20%. Okay, this is, and here's again, Harvard School of Public Health looking at 75,000 women prospectively followed for 16 years. Even after controlling for prior religious attendance, there is a reduction in risk of dying from a stroke among those who are attending religious services, really to any degree compared to those who are not attending at all. And again, you see a P for trend, suggesting a causal relationship. Now, this is out of the country of Iran. And if you are deeply religious in Iran, you do better in terms of coronary heart disease. Again, this relationship is not only found in the US, but it's also found in other countries, and in particular, the Middle East. Now, what about all-cause mortality? Well, of the 120 studies that have examined this in prospective studies, close to 70% find that religious people live longer. And about 6% of studies find that they don't live as long. And we think that the reason for those other studies, that 6%, is because as people get closer to death, they're more likely to turn to religion. So there seems to be this dynamic over time, people turning to religion. Just as if they become anxious, they turn to religion. People get closer to death, they get anxious, they turn to religious faith. And so sometimes in studies of like nursing home patients, you find a positive relationship between religious involvement and greater mortality. But in general, most studies find lower risk of mortality. And that's true for the latest studies out of Harvard as well. This is in JAMA Internal Medicine. The risk of all-cause mortality among those attending weekly or more than weekly is about 25% to 1/3 lower among that group compared to those who don't attend services at all. Again, you see this gradient of effect, suggesting a causal relationship. This is death rate from cardiovascular disease. That's where the effects are greatest. But the effects are also true for cancer mortality. And among young people, this is again another Harvard study in the 10,000 young people that they've been following for up to 6 years, the risk of developing cancer among 23-year-olds over a 6-year period is almost, it looks like almost 60%, more than 60% lower risk among those attending religious services at least once a week or more. So this religious involvement seems to be now actually there's actually a mechanism I forgot to put in the slide, but the cancer suppressor gene seems to be more active among those who are more religious, probably because the mechanism there is lowering rates of inflammation. Enhances the activity of this cancer suppressor gene, which religious involvement lowers the risk of inflammation, which lowers the risk of which increases the activity of the cancer suppressor gene, which lowers the risk of developing cancer. So there are actually biological mechanisms to explain how religious involvement does this. Okay, so basically, if you look at all of the studies published in the 2012 edition of the Handbook of Religion and Health, you find the majority find a positive relationship. And so this is, there are nearly 2,500 studies showing this now. I mean, you can't ignore this anymore clinically. How can you ignore a social factor that has this impact on mental, social, and physical health? You can't. Not if you're a scientist, at least. Here's a model that helps to explain this relationship. Now, this is a model within the Western religious traditions, the monotheistic traditions. We've got a model in the handbook. This is out of the 3rd edition of the handbook for Eastern religious traditions and for secular humanism. But in any case, for the more monotheistic traditions of Islam, Christianity, and Judaism, the source of these benefits is a person's belief in and attachment to God. And that then gives rise to the theological virtues of faith in God, hope in God, and love of God. And this is nurtured within a religious community and also affected by peer influences, education, and training. And that then results in religious activity, both social religious activity, like attending religious services, private religious activities, religious commitment, religious experiences, and religious coping, which then affect decision-making, health behaviors, health maintenance activities, screening, and compliance, and then also enhance these human virtues, which result in positive emotions, social connections, and help to neutralize negative emotions, which affect the nervous system, the immune and endocrine system, and cardiovascular functions, which affect physical health and longevity. This, of course, is based on genetics. developmental experiences and personality, which influence all of these relationships. But independent of these biological and developmental factors, religious involvement does seem to have an influence on physical health and longevity. Now, of course, there are also arrows that go the other direction. And so, we have to take all of that into account as well. So what about applications? Very quickly. Physicians should take a spiritual history. Talk with patients about these issues. Don't be hesitant. Respect, value, and support the beliefs and practices of the patient. Identify the spiritual needs of the patient and ensure that someone meets those needs. Usually that'll involve referral over to a clergy person or a chaplain. Now, if the patient asks you to pray with them, I wouldn't hesitate to do that. I would just go ahead and do it. Have the patient say the prayer if you're uncomfortable with this, and then just say amen at the end. That's a good way to keep it patient-centered. Have the patient say the prayer. And then you put your hand on their shoulder and just say, amen. Amen just means let it be so. You don't have to be religious to say amen. It just means let it be so. That's the actual interpretation of amen in the Greek. Let it be so. So it doesn't acknowledge belief in God or, the Buddha or whoever. All it means is let it be so that this person's prayer to the divinity that they believe in, let it be so that it is answered. Okay. Now, I've got a book on spirituality and patient care that describes how to do this for mental health professionals, for medical doctors, for nurses, etc. And so here's an example of the spiritual history. This is the brief spiritual history for medical doctors. This is specifically for doctors. This is out of the Journal of the American Medical Association. 5 very simple questions. Do your beliefs provide comfort? Or alternatively, are they a source of stress? Do you have any religious beliefs that might influence your medical decisions? Are you a member of a faith community, such as a church, synagogue, or mosque? And if yes, is it supportive? Do you have any other spiritual concerns that you would like someone to address? And again, the doctor is not going to be doing the addressing. They're going to be referring patients to somebody who's been trained to do that. Besides taking a spiritual history, support the religious and spiritual beliefs of the patient, both verbally and non-verbally. Ensure that the patient has resources to support their spirituality and accommodate the environment to meet the spiritual needs of patients. Now, we have 5 CME qualified training videos for how to integrate spirituality into patient care. You can go to our website, our Duke website, and you can download them for free. Now, to get CME, you're going to have to pay. But to just watch the videos, there are 3 videos for physicians, 1 video for nurses, and then a video for the spiritual care team, because this is a team approach. That's what's required to address these holistic spiritual needs of patients. Conclusion, religious involvement is related to better mental, social, behavioral health, and it improves these aspects of health over time. As religious involvement lessens, the result of increasing secularization, crime, alcohol, drug use, and addiction rates are all increasing. So as our country becomes less and less religious, we're finding all of these social problems now increasing in prevalence, as well as mental health problems. Religious involvement is also related to better physical health, less functional disability, and less cognitive decline with aging. I didn't go over some of those studies because I'm limited in time. These findings have huge implications for public health and healthcare costs as religious involvement becomes less common with each younger generation. So we need to improve the religious environment and the spiritual growth of our young people in particular. Clinical applications of the research are vast in terms of provision of mental and physical health care. And further resources, here's the book on spirituality and patient care. There are 3 editions of this book. Sign up for our e-newsletter. It's free. You can just go to our website, sign up. It provides the latest research. Comes out every month for free. And if you want a copy of these slides, don't hesitate to email me. I'll send you a PDF of the slides so you don't have to take notes. And our research seminar, August 14 through the 18th, this coming August, it's 5 days that compresses a 2-year postdoctoral fellowship into 5 days. Very intense. We have researchers from Duke, Yale University, Emory, Johns Hopkins coming in and teaching this. And we have some partial tuition scholarships that are available for students. And we go over everything. We've got theologians that come in and teach, but it's really focused on conducting research and some on clinical applications. Okay, now if you can't come to the workshop, I've written a book that summarizes the content of the workshop, and this is actually required reading for anyone who attends the workshop. It really goes into the research and the actual methods of research. Here's our website, and we've got a little time for questions and discussion.
Thank you so much for this impressive talk and the data, and really we are very grateful to you. Quickly, let me go through some questions I received from some Greek psychiatrists, in fact. So the first question is translated as following. Is there a method allowing us to teach new doctors, and more specifically psychiatrists, on how to detect and make good use of the religious emotion of their patients?
Yes, those videos that I was describing earlier on our website that you can access, those 5 videos, are very helpful in learning how to assess spirituality, how to go about integrating it into patient care. And that includes for psychiatrists, although in general, those 5 videos are for medical clinicians. Now, I actually have a PDF of a psychiatric curriculum for psychiatric residencies that can be taught. That was developed by David Larson back about 20 years ago and his team. And I have a PDF of it, and it goes through the psychiatric curriculum for training psychiatry residents to, again, address these issues and integrate it into clinical practice. And we've developed some interventions for depression and anxiety, and they're actually on our website. They have been tested in a randomized clinical trial. So again, our website is a good source for information in this regard.
The next question says, in 2001, in one of your publications entitled Religion and Mental Health, Evidence for an Association, you have mapped the field, suggesting means of assessing the religiosity of the treated ones. At that time, you did mention that the empirical research on this topic was at an initial stage. A, today, how much progress do we have? B, where could we look in order to organize a training program of the psychiatry residents in our country? Are there any guidelines or any other such syllabus?
Yes, as I indicated to the last question, I've got a syllabus for the training of psychiatry residents. Just send me an email. I'm happy to send it to you. With regard to the first question, there has been in the last 20 years, there has been an explosion of research in this area. And that research is documented in the Handbook of Religion and Health, the 3rd edition. That is actually Harold Koenig has written the introduction to the 3rd edition. And then Tyler Vanderweel and John Petit at Harvard are my co-authors. And so that is coming out in June. We actually submitted it to Oxford University Press in 2021, and they are now still working on it to try to get it into a publication form. It's 2,000 pages. It has thousands of studies, the best research in the world. All is in this journal, along with clinical applications. All it's in this book. So this book will be the premier source of research in clinical practice for religion and health in the world come June of this year. So that's where you can really find the research. You can look at it. Tyler Vanderweel is a biostatistician. He has looked over all of this research that we're reporting here, and he's put his stamp on it to be good research. So I think you'll find that extremely useful in terms of both doing research and in terms of clinical applications.
Another question is as follows. Should a physician share their religious faith with patients?
Well, a physician should be the best doctor that they can be. Competent, compassionate, and caring. And that by itself is a good way to share their religious faith with their patients, by doing a good job, by being an outstanding physician. Now, if the patient asks the physician their own beliefs, then the physician can respond. But I would not be, sharing your religious beliefs or trying to convert patients. Most patients are already religious. You don't have to convert them. All you got to do is to support their own religious beliefs, and you can do a great deal of good. And in particular, provide good medical care. That's the best way to share your faith.
And I think the last question is as follows. Why is the physician taking a spiritual history so important?
The reason why taking a spiritual history is important is because of the impact that religion can have on a person's physical health and mental health as well. It can be a powerful resource for healing, and it can also be a negative resource that can adversely affect the person's health if they're worrying about going to hell, or they have religious beliefs that prevent them from complying with medical treatments. You've got to know if you have a powerful social force that influences compliance with medication, you've got to know that. You've got to know whether you have a Jehovah's Witness or that doesn't accept blood products or other, individuals that want to stop their medication because they've been healed. So you've got to understand what role that religion and spirituality play in that person's life. And again, it doesn't take a great deal of time. Those 5 questions don't take more than a minute or two. And over the long term, they can save you time, actually. Now, for myself, sometimes when I don't have any time, I'll just ask the patient, I'll say, hey, how are you doing spiritually? How are you doing in your spiritual life? And then let them talk for a minute or two. And that a lot of times does a great deal. It bonds the patient, particularly the religious or spiritual patient, with the physician, and will make them more likely to do what the physician says.
With this, I want again to thank you so much for this wonderful hour we had together. And I hope all the audience could take advantage of the information you provide us, and hope to see you soon somewhere, virtually or physically, in Durham. Thank you so much. Have a nice
day. Dr. Linus. Thank you.
Thank
you. God bless you.
Bye. Bye. Same.